responses to injurious agents, hypersensitivity diseases, that we will study in the chapter of diseases of the immune system. And prolonged exposure to potentially toxic agents, either exogenous or endogenous. So, toxic agents, such as those workers that work in mines, they get some lung diseases such as silicosis. So, silicosis is a chronic lung disease. Or atherosclerosis, the origin of which is the most important origin of atherosclerosis is hypercholesterolemia that injures endothelial cells. So, this chronic inflammation can be the origin of some diseases such as Alzheimer's disease and neurodegenerative disease and metabolic syndrome and type 2 diabetes. Metabolic syndrome, have you heard of this syndrome? Metabolic syndrome is used when a patient is obese, has hypertension, has hypercholesterolemia. So it's the presence of some symptoms and signs together, then we use the term metabolic syndrome. And type 2 diabetes, these are chronic diseases. And even some cancers, they develop due to chronic inflammatory reactions. So cancers in some areas in body develop due to chronic inflammation. Morphologic features. The types of cells that are present in chronic inflammation are different from acute inflammation. In acute inflammation, the most important inflammatory cell is neutrophil. That has 3-4 lobes. This is the neutrophil in acute inflammation. But in chronic inflammation, the types of cells are different. They are monocytes. These monocytes, when they exit the vessels, in tissues, they are called macrophages. So, the most important cells in chronic inflammation are monocytes and macrophages. Also, dendritic cells are a kind of dendritic cell is a kind of macrophage. Dendritic cell. So, monocytes in blood, when enter tissues, they are called macrophages. Dendritic cells are cells like macrophages under the skin, under the epidermis of the skin. And also the other cells of chronic inflammatory cells are lymphocytes. These monocytes have a bean-shaped nucleus. Lymphocytes are smaller with a round nucleus. And also eosinophils, which have 2 lobes, and eosinophilic. And basophils. Eosinophils are present in allergic reactions. And they have some granules that can kill parasites, so worms. That's why in a reaction with parasitic diseases, there is infiltration of eosinophils and also basophils. So in chronic inflammation, types of cells are different. No neutrophils, but monocytes, macrophages, and also lymphocytes, eosinophils, and basophils. So types of cells are different in chronic inflammation. Not the same cells. So we can diagnose, for example, here, these are the alveolar spaces of lung. Alveolar spaces of lung, and these are inflammatory cells, most of them are lymphocytes. So it shows a chronic inflammation. If we see accumulation of neutrophils, it shows acute inflammation. So macrophages are the most important cells in chronic inflammation. It shows this is a monocyte with bean-shaped nucleus. This is in electron microscopy. So these monocytes, when enter tissues, they are called macrophages. So these are the most important cells in chronic inflammation. Then lymphocytes. Lymphocytes are divided into T and B lymphocytes. When we say T, it means that these T lymphocytes mature in thymus. That's why we say T. B lymphocytes mature in bone marrow. Both lymphocytes are developed in bone marrow, but the maturation site is different. For T lymphocytes is in thymus gland, but for B lymphocytes is in bone marrow. So lymphocytes also are important in chronic inflammation. B lymphocytes change to plasma cells. Plasma cells make antibodies. And the T lymphocytes, so there are two types of immune responses due to T and B lymphocytes. B lymphocytes by producing antibodies, but T lymphocytes, they make the cell-mediated type of immune response with different types of T cells. It depends on the type of receptor that they have. We have T helper cells, cytotoxic killer cells. One of the important receptors for T lymphocyte is CD4 and the other is CD8. CD8 T lymphocytes are cytotoxic T cells that can kill infected cells directly. So CD8 plus T cells and CD4 plus T cells. These CD8 plus T cells are cytotoxic T cells. It means that they can kill the infected cells directly, but CD4 plus T cells, they cannot kill the cells directly, but they participate in immune reactions that activate other cells such as B cells. So the other cells, including eosinophils, especially in allergies, in parasitic diseases. Also mast cells. Mast cells are cells that they have many granules, including preformed granules and some granules that are activated when there should be an immune response. So mast cells are also important. For example, histamine is a very important chemical mediator that can be produced by mast cells in reactions such as in asthma. Granulomatous inflammation is a type of chronic inflammation that, for example, can be seen in tuberculosis. Granuloma is formed by some type of macrophages that are called epithelioid cells. So macrophages change to these types of epithelioid cells. They proliferate, and together with the lymphocytes, so chronic inflammatory cells, epithelioid cell, oid means like. Some cells like epithelial cells, but they are macrophages. And multinucleated giant cells that it's only a single cell containing many nuclei. So it's called multinucleated giant cell. So this is a granuloma composed of epithelioid cells, lymphocytes, and the multinucleated giant cells. They are surrounded by collagen fibrils. So there can be multiple granuloma separated by collagen fibrils, and if they have necrosis, so their central part may have necrosis, which the type of necrosis is caseous necrosis in tuberculosis and others, some other fungal diseases. So tuberculosis is a type of granulomatous inflammation with necrosis, and the type of necrosis is caseous necrosis. Another cause for granuloma formation is foreign body. A piece of glass, anything can body reacts to this foreign body and makes granulomas. So foreign body granulomas, or granulomas due to infections, tuberculosis. Here is a picture of granuloma. These are multinucleated giant cell, and this is the central necrotic area. Systemic effects of inflammation by releasing of some chemical mediators, the most important of which are interleukin-1 and tumor necrosis factor. These are very important in the production of fever. So fever is one of the systemic manifestations of chronic inflammation, and chemical mediators are important in development of fever. Interleukin-1 and tumor necrosis factor are important for this, because these activate or stimulate hypothalamus in production of prostaglandins, especially prostaglandin E2, and that causes increase of temperature. So fever as a systemic manifestation of chronic inflammation, and the importance of chemical mediators, interleukin-1 especially, and tumor necrosis factor. Leukocytosis can be a systemic manifestation of chronic inflammation. It means increase in number of white blood cells. Leukocytosis means increased number of white blood cells. And in acute inflammation, neutrophils are increased in number. In chronic inflammation, chronic inflammatory cells, especially lymphocytes, are increased in number. So when neutrophils are increased in number, we call it neutrophilia. If the lymphocytes are increased in number, we call lymphocytosis. If eosinophils are increased in number, we say eosinophilia. And if leukocytes are decreased in number, we call it leukopenia. So leukocytosis is increased, leukopenia is decreased. And they have different types. If this leukocytosis is due to increase in neutrophils, it's neutrophilia. If it is due to lymphocytosis, eosinophilia, or if decreased in number, leukopenia. And what is repair? So a chronic inflammation should be repaired. If there is a chronic inflammation such as an ulceration in the skin or in the stomach, which is called peptic ulcer, it should be repaired. So after chronic inflammation, we study tissue repair. It depends on the cells that are supposed to be repaired. Some cells are sensitive to injury, so tissue repair depends on the type of cell that has been injured, and if the cell has the ability to regenerate or not. So some cells such as skin cells, squamous epithelial cells, or intestinal mucosal epithelial cells, they regenerate easily. So these cells can proliferate and make new cells. They regenerate. But some cells, such as liver cells, smooth muscle cells, if they are stimulated, they regenerate. If there is an injury to liver, then they start to proliferate and make new tissue. So it depends on the type of, these cells are always present at the G1 phase of cell cycle. These are present as G0, but when they are stimulated, they can go to G1 phase and start proliferating. But some cells, such as neurons, skeletal muscle cells, and cardiac myocytes, are permanent cells. These are permanent cells. They cannot proliferate. So injury depends on the type of cell. If there is injury to neurons or skeletal muscle cells or cardiac myocyte, such as myocardial infarction in heart, so these cardiac myocytes cannot proliferate if they are injured. If there is death or necrosis of these cells, then repair is the repair tissue that occupies the necrotic tissue is only scar tissue. No cardiac myocyte can proliferate, and all the repair tissue is scar tissue. But if these cells that regenerate easily, they are injured, most of the tissue is fully regenerated, and the scar tissue is very little. If the type of injury is mild and not deep, all the tissue can be regenerated. But if the tissue injury is severe and many cells have been injured, so some scar tissue will also develop in these cells, but not as much as the scar tissue for permanent cells. So it depends on the cell type. If the tissue cannot proliferate, all the repair is scar tissue, which is produced by fibroblasts. They produce collagen fibrils. So all the tissue is scar tissue or fibrosis. Fibrosis means production of collagen by fibroblasts. So the cells that make this scar tissue are fibroblasts. They are elongated cells with nuclei, but their cytoplasm, all the cell is elongated. So these fibroblasts, they proliferate. Fibrosis is proliferation of these fibroblasts and making collagen. This is fibrosis. This and this makes the scar. So repair depends on the type of tissue and the ability of the cell to regenerate completely or not. So imagine this is normal tissue, for example skin, there is mild superficial injury here, and then it can regenerate completely with no scar formation. But here, the injury is severe, is deep. There is a layer at the, for example, for skin, between the epidermis and dermis that is called basal layer. The cell at the basal layer have the ability to regenerate. If this basal layer is not injured, it's much easier to regenerate all the tissue. But if the basal layer is injured, then we will have some scar tissue. Here, it is the scar that is composed of those fibroblasts that are elongated cells and make collagen. So this is the scar tissue. I explained the different types of cells that permanent, labile, and stable. Labile are those that are G1 phase and stable, G0 phase that can change to G1 when they are injured. And what happens in regeneration? This is liver regeneration, which as you know, if liver is ruptured or injured severely in an accident, after some months, all the liver can be regenerated and these cells proliferate. And so it was an example of hyperplasia, as you remember. Hyperplasia, and all the liver is renal. They produce some growth factors that can repair the tissue. Now, what are the steps in scar formation? We have some types of tissue repair, but after So what are the steps to form a scar? First of all, we have acute inflammation when there is an injury, acute inflammation. So in acute inflammation, neutrophils are accumulated. Then this acute inflammation changes to chronic inflammation. And then this chronic inflammation should be repaired and maybe repaired by scar tissue formation. Now, so if, imagine this is skin tissue, skin epidermis, that is composed of stratified squamous epithelial cells. And this is the basal layer that has the ability to make these squamous epithelial cells of epidermis. So first of all, when there is injury here, abrasion here, there will be an acute inflammation. And as we studied in acute inflammation, imagine this is a vessel that passes or is near the epidermis, and we saw that this neutrophil can do rolling, then firm adhesion, and then transmigration, and then chemotaxis to this area. So all the steps happen. Transmigration or diapedesis, chemotaxis, and traveling of this neutrophil to this site for phagocytosis. So first of all, neutrophils, they accumulate here to kill the microorganisms or the foreign body that has injured this area. Then little by time, these neutrophils are disappeared, and instead of them in chronic inflammation, we have the macrophages. and dendritic cells that are present in dermis of the skin, and they have long cytoplasm. These are dendritic cells. So in chronic inflammatory cells, especially macrophages, dendritic cells, and lymphocytes, and it depends on the type of injury. Lymphocytes or eosinophils when there is allergic reaction or parasitic infection. Instead of lymphocytes, most of the cells are eosinophils. So in chronic inflammation, these neutrophils little by little disappear, and instead of them, these chronic inflammatory cells are accumulated at the site of injury. Now, something else happens in addition to accumulation of inflammatory cells, and that is angiogenesis. Means making new vessels. So, in addition to accumulation of chronic inflammatory cells, angiogenesis means development of new vessels. So new vessels are formed in this tissue. And this tissue that contains both chronic inflammatory cells and new vessels is called granulation tissue. So before scar tissue formation, there is granulation tissue formation. That is an edematous connective tissue with chronic inflammatory cells and many vessels. If we do a cut section of this granulation tissue, we will see many small vessels together with macrophages and lymphocytes. So this will be the picture. These are vessels and these are inflammatory cells and some connective tissue in collagen, just little. So this is granulation tissue. Then this granulation tissue is changed to scar tissue. By what? By formation of collagen. But collagen has some types. First, collagen type 3 is formed, which is weak, is not strong enough. And little by little, this collagen is changed to collagen type 1, which is the strong type of collagen. And it needs 2 months for forming a strong scar tissue. So, in which most of the collagen is type 1. So, after 2 months, a strong scar tissue is formed. And that depends on the type of collagen that we have. First, collagen type 3, that is weak. And maybe it's has only 10 to 20% of the 10 to 20% of a normal tissue, strength of a normal tissue. But this type 1 collagen has 80%, is 80% in comparison with collagen type 3 of a normal tissue. So it's strong. So these are the steps that happen for scar tissue formation. First, we have acute inflammation and neutrophils. Then the neutrophils are changed by chronic inflammatory cells. And then granulation tissue is formed due to angiogenesis. And then there is collagen accumulation, and by time, a strong scar tissue is formed. In angiogenesis, imagine these are 2 vessels, and a new vessel should be formed. So these vessels are lined by endothelial cells. To make a new blood vessel, these endothelial cells, they secrete some growth factors, such as VEGF, vascular endothelial growth factor. there are different growth factors. Fibroblast growth factor, platelet-derived growth factor. We have many growth factors. One of the important of these is VEGF, which means vascular endothelial growth factor. It's produced by endothelial cells, and little by little, the basement membrane of this vessel is opened, and this endothelial cells exits and start to proliferate by the production of these growth factors, also from this side. So these endothelial cells start to proliferate and bind to each other. And then, little by little, a canal is formed between these vessels, and this is a new vessel. So this is angiogenesis. This is angiogenesis and the formation of new vessel for granulation tissue formation. What?
Like pulmonary.
Pulmonary vessels, lung vessels. You mean that new vessel formation in lung during embryogenesis, you mean? Maybe. So, angiogenesis and formation of granulation tissue. This is the normal tissue, then there is tissue injury, then there is acute inflammation, when then changes, most of the cell change to chronic types, and you see here, there is angiogenesis. New vessels are formed from the vessels that are present there. New vessels are formed. This is angiogenesis, and new blood vessel formation with chronic inflammatory cells, and these elongated cells are fibroblasts that they produce collagen. So together this is called granulation tissue, and when the collagen is increased in tissue, it is called a scar. This is a granulation tissue. All these reddish areas are new vessels. All these are new vessels, and you see that there are some empty spaces between the vessels. It's edema. Since fluid, water, any liquid cannot be seen, cannot be stained in hematoxylinosin staining in histology, so the empty spaces mean presence of fluid, presence of edema. So this is an edematous connective tissue containing many new blood vessels. It's called granulation tissue. And angiogenesis, that's what I told you, that a new blood vessel is formed. So there are some factors that they can influence the repair. If the tissue has infection, then the repair will be delayed, will be prolonged. So the most common cause of delaying or prolonging of the tissue repair is infection. And then diabetes. Diabetes also by increasing the level of glucose in tissue, and hypooxygenation, it increases the possibility of infection at that site, and it prolongs tissue repair. The nutritional status, if there is malnutrition, so hypoproteinemia and also vitamin C deficiency, these impair tissue repair. And some hormones such as glucocorticoids, they have effect on the time of tissue repair. Mechanical factors, poor perfusion means when the vessels have problem and cannot nourish the injured area normally. Foreign bodies, type and extent of tissue injury, and location of injury is also important. One of the examples, the common examples for tissue repair is for skin wounds. And here we have three types of clinical terms for repair or wound repair. They are called healing by first intention, healing by second intention, and then we have also the third type, tertiary, that it shows by the type of the injury, its severity. We choose that we make a suture for the injury or not. Healing by first intention means that the injury is not severe, and then we make a suture for the injured area, and the healing is rapid. But if the injured area is large and infected, especially, is not clean, then healing by second intention means that we leave the injured area open, we don't suture, and then this injured area heals by itself. So the granulation tissue is bigger and the scar tissue is also bigger. In the third type of healing is that the injured area is very infected, so we have to use some antibiotics and debridement for the tissue. We clean it, we use some topical and systemic antibiotics for the injured area, and then after that we can do some suturing or whatever, implanting, and the third type is the most prolonged type of healing. So it depends on the severity of the injured site, and if it is clean or not. This is a skin ulcer that the microscopic picture shows this is the ulcerated area where here there is granulation tissue formation by formation of new blood, where all of these are blood vessels. And then there is collagen formation and scar tissue. So first scar, then granulation tissue, and then the scar tissue. This repair is also present in other tissues such as in liver, in lung, in brain. In brain, as we said, the cell, the neurons cannot proliferate, and the supporting cells of neurons such as astrocytes and the glial cells as macrophages, they proliferate and make reaction. In lung tissue, we have two types of cells that line the alveoli. So we explained liver that it can regenerate by secretion of new growth factors by hepatocytes. Lung also is composed of alveolar spaces, so the large airways, they divide into smaller branches, and at last we have alveolar spaces, alveoli. Alveoli are lined by pneumocytes. Pneumocytes type 2 and type 1. So, pneumocytes. Type 1 are elongated cells. So they are long cells that line the alveoli. And type 2 pneumocytes are smaller, not long cells, type 2 pneumocytes. These type 2 pneumocytes that are present in lower number than type 1, they have the ability to regenerate. So these type 2 pneumocytes regenerate and they can make type 1 cells. So if there is injury to alveolar cells, type 2 pneumocytes have the ability to regenerate and make new type 1 cells. So in lung, this is what happens when there is lung injury. You also have the file of this chapter. It has some other pictures for different patterns of tissue regeneration, so pay attention to them and also study the what we start this hemodynamic chapter. So, after the chapter of inflammation and repair, we start the hemodynamic disorders, thromboembolic disease and shock. And then today, for the other groups, we were explaining embolism, thromboembolic disease, that is embolization of thrombosis. And now for you, we start this chapter with the explanation of edema, hyperemia, congestion. So what does it mean that we say disorders of hemodynamics? It includes edema, effusion, congestion, and shock. Edema, when fluid is accumulated in tissues. So hemodynamic disorders Hemodynamic disorders include edema, effusion, shock. Edema means increased fluid in tissues, but effusion means increased fluid in cavities. Cavities such as pleural effusion, pleural layer that covers lungs. Pleural effusion, peritoneal effusion, peritoneum that is present in overlying viscera of abdomen, peritoneum. So peritoneal effusion, it's also called ascites. And this pleural effusion is also called hydrothorax. Hydro, water in thorax. Or in the pericardium covering part, which will be called pericardial effusion. So if this fluid is accumulated in cavities, we have these types, or it can be seen in tissues. And in tissues, in any tissue, we can have edema, lung, liver, extremities. In tissues, the type of fluid can be transudate or exudate. What is the difference between these?
Protein content.
Yes, the protein content in exudate is high and in transudate is low. So, exudative type of inflammation, exudative type of edema is seen in inflammation. So one of the causes of edema is inflammation, being acute or chronic, and the edema is exudative, is high protein level. But in other causes, and better to say most causes of edema cause transudate, which is low in protein. We have explained exudate, so now when we are explaining edema, we mean causes of transudative edema. What are the causes of non-inflammatory? This is inflammatory and this is non-inflammatory. What are the causes of non-inflammatory edema? Increased hydrostatic pressure. Or decreased colloid osmotic pressure. Or lymphatic obstruction. Or sodium retention. So these causes, 4 different causes, they can cause non-inflammatory edema, transudate. In a vessel, there is a balance between hydrostatic pressure and colloid osmotic pressure. There should be a balance between these 2 types of pressures in order that we don't have edema. If there is this hydrostatic pressure, it pushes the fluid outside the vessel. But colloid osmotic pressure pulls fluid inside the vessel. So they have reverse actions. There should be a balance between these 2. Normally there should be a balance between these 2 pressures in order that we don't have edema. Normally, a little fluid is extravasated through the vessels, but it is not edema because this fluid is removed by lymphatics. So lymph vessels have the duty to remove the interstitial fluid. And this is done rapidly. So normally we don't have edema. If there is some fluid in the interstitial space outside the vessels, these are rapidly removed by our lymphatic system. And so a normal person doesn't have edema. But if this pressure is high, hydrostatic pressure is high, so if there is, it means that, for example, the person has high blood volume. For example, heart failure. There is high blood volume, or there is sodium retention, high sodium, and this causes more water inside the vessel. This can cause increased blood volume and increased hydrostatic pressure, so there is extravasation of fluid to outside the vessel. Or for colloid osmotic pressure, here this pressure is developed by proteins. Proteins in serum, the most important is albumin. So if there is low albumin in blood, which is called hypoproteinemia, hypoalbuminemia, or generally hypoproteinemia. So if a patient has low protein level in serum, this will cause low colloid osmotic pressure, and it cannot pull the interstitial fluid to the vessel, and the patient will have edema. So if this pressure is low, the blood cannot be removed from the interstitial space. And what causes hypoproteinemia? If there is low albumin synthesis by liver, so if the patient has liver disease, liver failure. Any disease in liver can cause decreased synthesis of proteins, including albumin. So it will cause hypoproteinemia. So decreased production of proteins or increased loss. Increased loss of that is lost generally through urine, which is called proteinuria. So if the patient has high proteinuria, so has increased loss, or has liver failure, which means decreased production, both of them will have the same meaning. Hypoproteinemia, low level of protein in blood, especially albumin, which decreases this colloid osmotic pressure and will cause edema. So increased hydrostatic pressure, decreased colloid osmotic pressure, and lymphatic obstruction. If lymph vessels are obstructed, for example, post-surgery, one of the common causes of edema is due to lymphatic obstruction is surgery in women with breast cancer. Removing of breast tissue together with some lymph vessels and lymph nodes near the cancerous area, it causes problem of removing of the interstitial fluid by the lymphatics. So these patients usually have edema of upper extremities. So if lymph nodes together with breast are removed by this surgery, they usually have edematous upper extremities, left or right depending on the site of surgery. Or maybe lymphatics can be obstructed by parasites. You have heard of filariasis. Filariasis that obstructs the lymphatics and can cause elephantiasis. If lower extremity is very big due to filariasis, it is called elephantiasis. So this will also cause edema because of lymphatic obstruction. Or any tumor or being benign or malignant that can push the lymphatics to obstruct them. So lymphatic obstruction and sodium retention. When sodium cannot be excreted by the kidneys, then sodium will increase in serum, and this also increases water and blood volume in. So this sodium retention is another cause of edema due to heart failure or renal failure. So the patient can have problem in heart or kidney, and sodium cannot be reabsorbed completely, and this sodium retention together with water retention will cause edema. But in sodium retention, there is both increased hydrostatic pressure and decreased colloid osmotic pressure. So both of these factors play a role in sodium retention. But the type of edema is transudative. In all of these, the edema is non-inflammatory, is transudative. So this is the explanation for edema. For what? Elephantiasis. They use some drugs, yes, for filariasis. Or there are some drugs that they kill the parasites, the worms. They can kill their cell membranes. It has given complications. Maybe it has been late to. So if it gives some organ dysfunction, then just by killing the parasite, it's not enough, and some other things should be done as well.
So it has caused infarction maybe, because obstructing the vessel can cause ischemia, pushes the other vessels, including veins and arteries. That's the cause. Due to pressure to surrounding tissues, it is present in lymphatics, but since it pushes the surrounding vessels, it can cause infarction. And that's the complication. So the worms, the parasites are easy to treat. There are some drugs, but whatever you say is the complication of that filariasis that has caused the infarction, and so amputation is necessary for removing that infarcted area. So it has been prolonged, and the prolongation has many complications. So we studied edema, and this is a table for different causes of edema, including non-inflammatory, and the last is inflammatory, that is whatever we saw in the inflammation chapter. So there are two things that are important in the control of edema. If a patient has heart failure, renal failure, and this is, for example, renal liver failure, that there is low protein synthesis, or again, nephrotic syndrome is a renal problem where there is severe proteinuria. We have nephritic syndrome and nephrotic syndrome. In the nephrotic type renal disease, the patient has severe proteinuria, so there will be hypoproteinemia. Or if there is hepatic disease where protein synthesis is decreased, or malnutrition, the result of all this is the same, hypoproteinemia. This causes low osmotic pressure. And here, when there is heart failure, hydrostatic pressure is high, and this will cause edema. And in heart failure, there is low perfusion of kidneys, so there is activation of a system called renin-angiotensin system, where by activation of it, there will be retention of sodium and water. Also, renal failure can cause this retention. So, as we said, renal failure and heart failure can cause sodium retention, both of them. So we explain these things. Then we go for the other part, which is hyperemia and congestion. I explained today for the other groups that they didn't remember the difference between hyperemia and congestion. Both of these mean increased blood volume in tissues. But as I said, hyperemia is, we use this term when there is increased flow of blood in tissues, such as increased physical activity increases blood flow, or inflammation. But congestion is due to decreased outflow, so blood is accumulated in tissue, and it's pathologic. In the liver and lung, congestion is seen in right and left heart failure. And this is passive congestion, chronic congestion of liver, where there is necrosis. These darker areas they show necrosis. They are depressed tissues. So these darker areas are depressed tissues. The normal tissue is this depressed tissue. This is the depressed tissue. It shows the necrotic areas. Depressed necrotic tissue, which is the darker part. And the surrounding is healthy tissue, which is lighter.
Cause of this less
What?
Oxygen and nutrition.
This is due to congestion. Congestion means that blood is accumulated there, but hypooxygenated blood, not normal oxygenated one. So this more commonly is seen in right heart failure. In right heart failure, you imagine this is heart, this is the septum between the right ventricle and left ventricle. So right heart failure, this part of the ventricle cannot pump all the blood. So this goes back or backs up to the vena cava, superior and inferior vena cava. So here, due to the failure of the right ventricle, this venous blood goes back to the inferior vena cava and then to liver. So this venous blood is accumulated in liver tissue, and this is called congestion. So decreased outflow or increase the venous, which is hypooxygenated, low oxygen level, the tissue will become cyanotic. So it doesn't have enough oxygen, it pushes the tissues and the center of the lobules. If you imagine liver tissue is composed of different lobules. The center, these are the hepatocytes, so the central cells are more sensitive to lack of oxygen. So when there is hypooxygenation, the central cells will die. And that's what occurs here. These central cells make these depressed areas that are necrotic and darker. These are darker parts that are necrotic, and the lighter are the healthy tissue. This gives a nutmeg appearance to liver.
And liver
Nuts,
loses the ability.
nuts, you know they are dried fruits, khoshbar, ajil. Nutmeg is the type of nut that if you have seen has something, an appearance, something like this. That's why we use the term nutmeg liver. It's a sign of, it can be a sign of right heart failure. So this is congestion of liver. Again, in left heart failure, this part, when left ventricle cannot pump normally, so blood will back up the lungs. So due to lack of enough pumping, blood goes back to lungs and causes edema in lungs. And this causes congestion in lungs. Increased blood volume, but it will cause pulmonary edema. Means the alveolar spaces that they are clear and they are air spaces, they are filled with fluid. This is pulmonary edema, that the patient cannot inspire deeply.
With the fluid or the blood?
The cause is blood, but the interstitial fluid is extravasated, just few red blood cells, not all of it's bloody, but not as concentrated as blood. Some red blood cells, and as I said, these red blood cells are phagocytosed by macrophages. These red blood cells, heme is phagocytosed by macrophages, which contains iron, and that's why we call these macrophages heart failure cells. So in left heart failure, pulmonary edema causes accumulation of macrophages that contain iron. They are called heart failure cells. So heart failure cells in lung, and nutmeg liver in liver. Nutmeg appearance in liver.
So these are examples of congestion. And what is hemostasis? Hemostasis is the process, the normal process that occurs when there is an injury to a vessel for blood clotting. So hemostasis is a normal process that we should have to make a blood clot after a vascular injury. Hemostasis, it includes the roles of vessel walls, platelets, and coagulation factors. We should have normal platelets functioning, platelets with normal number. We should have normal vessel wall, and also we should have coagulation factors in enough degree of coagulation factors for having a normal hemostasis. So this is hemostasis. But if there is a problem in any of these, including platelets, if we have low number of platelets or dysfunctioning platelets, or if we have an abnormal vessel wall, weak vessel wall, and if we have low coagulation factors such as factor VIII, which causes hemophilia, factor VIII hemophilia A. So any of these factors that are important for having a normal hemostasis then will cause bleeding disorders or coagulation disorders. So we should know what happens in hemostasis. Have you studied in physiology or the hemostasis? When there is vascular injury, if we don't have normal hemostasis, when there is an injury, we will have bleeding, and this bleeding doesn't stop. Now, what are the steps in hemostasis? I am explaining all these rapidly in order not to have class tomorrow. I explained some part of embolism together with the other groups, and after that we finished chronic inflammation and repair and started the other chapters. So all of these I do faster than normal sessions to finish and be ready for the exam of Friday. So what is hemostasis? What occurs? The steps are, first there is vasoconstriction. Arteriolar vasoconstriction. This is a vessel lined by endothelial cells also this area. When there is an injury, so some of the endothelial cells, they are injured, and there is, under the endothelial cells, we have subendothelial matrix, which has collagen fibers. So when there is injury, the cells of the blood can be exposed to this collagen. The cells include neutrophils, lymphocytes, monocytes, red blood cells, and platelets. So these cells can sense this injured area. But first of all, when there is an injury due to neural reflex, and also endothelin produced by endothelial cells, these arterioles, it becomes narrower, it constricts. Why? To produce less bleeding, to control the bleeding.
So there is, first of all, there is vasoconstriction by neural reflex and production of endothelin by endothelial cells. Then this vessel constricts. It becomes narrower. Then what happens? So first is constriction and then is primary hemostasis. Then is secondary hemostasis. What is primary hemostasis? It means that after this vasoconstriction, these platelets that I imagine, these are platelets. First they are round. They come close to these collagen. They should bind this collagen. There is a receptor on these collagen fibers which is called von Willebrand factor. So collagen fibrils, they have a molecule called von Willebrand factor. And these platelets have a receptor called GPIB. This GPIB can bind to this. So platelet binds collagen. Imagine many platelets bind this collagen. Binding von Willebrand factor by their GPIB receptor. This is called adhesion. This binding of platelets to collagen is called adhesion. And during this binding, the platelets change their shape to discoid type. Why? To have a bigger surface. Because all the coagulation cascade occurs on their surface. So binding of different coagulation factors starting from tissue factor, then factor 7, then activation of different factors including 10, 5, prothrombin to thrombin. All of them occur on the surface of platelets. So there is a change of shape for these platelets. And also during this shape change, there is more phosphatidylserine, which is negative, to the surface. So phosphatidylserine, which is more present on the inner side of plasma membrane, during this stimulation, it comes out of the plasma membrane and makes a negative charge to the platelets. So this phospholipid, negative phospholipid layer makes a surface ready for binding the coagulation factors and the coagulation cascade. So this adhesion together with changing of shape of platelets happen. Then these platelets start to secrete some granules such as ADP, adenosine diphosphate, and thromboxane A2. These cause activation of other platelets. Other platelets recruit to this area and accumulate there, and this step is called aggregation. Aggregation means binding of platelets to each other. Adhesion means binding of platelets to collagen, but aggregation means binding of platelets to each other. And this binding is through another receptor called GP2B3A. GP2B3A. This is one platelet, this is another, but with the help of fibrinogen. So this aggregation is, which is called, this accumulation, which is called aggregation, is done through another type of receptor with the help of fibrinogen. GP2B3A to fibrinogen attaches platelets together, and we will have this aggregation which makes the hemostatic plug. This is primary hemostasis. So in primary hemostasis, this is the picture, platelet addition, so there is vasoconstriction, then von Willebrand factor on the collagen, and GPIB on the platelet. Through this platelet binds the collagen, then there is shape change. It makes a bigger surface for the platelets, and the surface becomes negative by phosphatidylserine, the granules secrete, and there is aggregation, attachment of platelets together. There is another picture here that shows these receptors. Von Willebrand factor, platelet with GPIB, but platelet to platelet with GP2B3A and fibrinogen. So here when we learn new molecules, then we learn new diseases. A disease called von Willebrand disease is due to deficiency of this von Willebrand factor. Von Willebrand disease is the most common heritable bleeding disorder. So maybe you know that hemophilia is the most common. No. Von Willebrand disease is the most common heritable bleeding disorder. Hemophilia is the most common heritable bleeding disorder that can cause dangerous bleeding. So hemophilia is important because it can cause life-threatening problem. But von Willebrand disease is the most common, but the type of bleeding in von Willebrand disease is usually mild. So this disease, when there is deficiency of GPIB, which causes adhesion, it's called Bernard-Soulier syndrome. And when there is deficiency of GP2B3A, it is called Glanzmann thrombasthenia. So these are bleeding disorders due to deficiency of receptors. So anytime you see that we learn new molecules, then we learn new diseases. Von Willebrand, Bernard-Soulier, and Glanzmann thrombasthenia. If you want to memorize this, GP2B3A is important for aggregation. So aggregation, the disease is Glanzmann. Both have G. Bernard-Soulier is for adhesion. After A is B. Adhesion, Bernard-Soulier disease. So GPIB deficiency, which is important for adhesion, the disease is Bernard-Soulier. We have break time, yes?
Yes.
So after the break time, we will continue.